Good evening and a very, very warm welcome. Perhaps at least we're meeting after a relatively long, painful period of almost 2.5 years. I apologize for having started late. It is because of reasons beyond my control. So without wasting much time, I'll just introduce two things. The whole idea behind this fluid thing is that, in acute care, we talk a lot about trauma, we talk a lot about antibiotics, ventilation, hemodynamics. And most of us actually, are at loss of what fluids, what is actually fluid resuscitation, what is the type of fluid that should be given, how much, how less. These are questions that at least I didn't read in my medical books, probably my fault or the systems. So we thought that this would be something that we all need to learn. So we are very fortunate today that we have two of the best speakers on the subject, which the chairperson sir will introduce. So to start the proceedings, I invite today's chairpersons, Dr. Bhargav sir. He's our stalwart of critical care in Jaipur. Dr. Suresh Bhargav. He's heading Department of Critical Care Medicine at Shelby Hospital. All of us know him. So he has been the vice president of Indian Association of Anesthesia, and he has a long list. So I invite Dr. Bhargav sir. I would also like to invite Dr. Shrishti Jain as the second chairperson. She is one of the most enthusiastic established intensivists today. She's probably by now professor or associate professor, Department of Critical Care Medicine at Mahatma Gandhi Hospital. So friends, next 1.5 to 2 hours, let's enjoy learning. Thank you.
Good evening, everybody. I welcome Dr. Supradeep Ghosh, who is Director Fortis Faridabad. And he's a... Please. And our today's other speaker is Dr. Narang. I think he is on the way, and he will be coming in half an hour. Then I invite our other speaker, Dr. Pankaj Anand, and everybody knows Dr. Pankaj Anand. He is a very great intensivist as well as great organizer, and his organizing capacity, I'm watching this last 10 years, and he developed this ACE, and he has given some type of academy at Jaipur, and that is very I can say that Jaipur was not having any sort of organization or any society of intensive care or critical care, but he established on his own level, and he is running it very well. I welcome him.
Because probably our chairperson might have to go, so we'll just have a small bouquet presentation. I'll invite Mr. Mohit to please come over and give a bouquet to our chairperson, Dr. Suresh Bhargav sir. Anshu ma'am, please. Dr. Supradeep. Fauzia, ma'am. Shishri. Rajneesh, sir. This is just a gesture that.
फूलों की तरह खिलखिलाते हुए चेहरे को हम इसी उम्मीद से याद करते हैं कि वो लोगों को भी जो मरीज बन के आते हैं उम्मीद से उनका भी चेहरा
Mohit. Mohit Changani is from Fresenius, who've been kind enough to.
Now I invite Dr. Pankaj. His topic is neurotrauma and fluid balance.
So actually, Dr. Achin Narang, who's coming from Chandigarh, he was to start the proceedings today. Unfortunately, he missed his flight, and he's been so kind to actually grab a cab, and he's, running all the way here. So he would be coming probably in next half an hour. So I have the honors to start the proceedings. The entire concept of resuscitation, fluid resuscitation differs. There are certain broad principles, but when you talk about certain specific groups, neuropathology, largely neurotrauma is one group where you have to consider certain specific situations where your fluid resuscitation dynamics or principles change. So I'll start with a small case history. This was a 45-year-old gentleman. He was actually going in his car and he collided had a crash with a truck. He weighed around 68 kgs, came to us in the emergency department. Now, when he came there, he was bleeding profusely, had a altered consciousness. We took a detailed history. He was a known case of diabetes. There were no other reported comorbidities or allergies. There was never a talk where this thing worked flawlessly. Sorry. It's not moving, man. You do it yourself. So go back, please. Right. Next slide. Next. So when we saw him in the ER, he was obviously tachycardic. His blood pressure was 74/40. No fever, of course, but his saturation was 92% on room air. He was tachypneic, had a cold, clammy skin, was disoriented in time, place, and person. Next. So while we were resuscitating, we also sent the investigations the way we do with all patients. So his hemoglobin was 6.1 with a hematocrit of 22. His INR was 1.6. The ABG showed a pH of 7.12. So this is a case of mixed acidosis with a PaCO2 of 51, a PaO2 of 87, and the bicar was 20. His sodium was 132, chloride was 108. glucose 284, and the lactate was 8.6. Further investigations, he had an open fracture of the left femur, a closed fracture of left humerus, and also a left maxilla fracture. The CT cervical spine was largely normal. Ultrasound did not show any free fluid in the abdominal cavity. His X-ray chest was normal. There were no fractures or abnormalities. NCCT brain showed a mild subarachnoid hemorrhage with bleeding into the right ventricle. So we did what everyone would do, an A, B, C, D, E of ATLS. We put two large bore 14 French cannulas, pushed in fluid, almost 3.5 liters of normal saline was given along with 2 units of blood, PRBCs. He also needed inotropic support in the form of noradrenaline. External immobilization of the left femur was done, followed by a visit to the OR where it was reduced and stabilized. He came back from the operation theater after 3 hours of surgery with the endotracheal tube in situ, and during the procedure, he was again resuscitated with normal saline only. When he came back to us, we repeated an arterial blood gas analysis. The hemoglobin was 8.2. We were given 2 PRBCs, right? And the ABG, the pH was now 7.10. If you remember, previously it was 7.12. The bicarb had come down from 20 to 18. Sodium had gone up to 144. The chloride from 108 is now 118. The lactate, fortunately, has come down from 8 something to 4.5 now. Another unit of PRBC was given. The patient had a urine output which was around 20 to 25 ml per hour initially post-surgery. But after around 8 to 10 hours of further resuscitation with normal saline at a rate of 125 ml per hour, it improved and the hemoglobin stabilized to around 9.7 milligrams per deciliter. So gradually the hemodynamic parameters improved. We were off noradrenaline. In the ICU, the patient was obviously mechanically ventilated following the parameters and was obviously monitored very closely. 2 days in the ICU, the patient showed improvement in a lot of almost all biochemical parameters. Repeat NCCT head revealed no further increase in the bleed. So on day 3, we were able to extubate this patient. So I'm not here to discuss the trauma care. I'm not discussing the CTs and all. We are here to discuss the fluid. And what made me think in this patient was that would it have been a better idea if instead of normal saline, I would have used a balanced salt solution. Why? In this patient, fortunately, he was resuscitated, and as most of our patients do get resuscitated with normal saline. But if you see that this patient actually developed a worsening of his acidosis, what is termed as hyperchloremic metabolic acidosis, and especially in a patient who's hypotensive, has issues with renal output or an AKI, this I personally believed that I should have used a more balanced solution rather than using normal saline. Next slide, please. Next slide. So next. So there are benefits that might have been incurred by changing to balanced salt solutions, and the chances of acute kidney injury with the use of large volumes of normal saline, which is superimposed in a hypovolemic shock, actually made the patient more prone to kidney damage. Next. So coming to the specific scenario of neurotrauma, there are certain pathophysiological processes which are pretty specific to it. We all know that there are definitely higher chances of developing cerebral edema formation. Obviously, increased intracranial pressure is an issue, and these patients have a relatively low tolerance for hypoxia. They are more prone to what is termed as the second injury which we all know is hypotension and hypoxia. Next. So the fluid management in a critically ill brain injured patient is largely aimed at maintaining an adequate cerebral blood flow and oxygenation. And we all know that the CPP, or the cerebral perfusion pressure, is basically the difference between the mean arterial pressure and the intracranial pressure, both of which you need to closely monitor and manage. Next. So the effect of fluid management on cerebral blood flow and oxygenation, we know, is complex and depends on a lot of factors. It depends on how much fluid you are giving, what type of fluid you are giving, what is the tonicity of the fluid, what is the volume of the fluid. It depends on the patient-specific factors as to what is the status of the blood-brain barrier, the CSF circulation and volume, how much is the inflammation, how damaged is the autoregulatory mechanism of the brain, what is the venous impedance, what is happening to the seismic circulation, which then depends on what is the status of the heart and what is the status of the vascular tone and permeability. And of course, cerebral edema and the cerebral blood flow and oxygenation play a key role. Next. So if you talk about the osmolality under normal circumstances, the osmolality of the plasma is same as that in the brain interstitial fluid. But once your blood-brain barrier gets disrupted, the hemostasis gets abolished. So if you're giving a hypotonic fluid, it would definitely cause a water shift within the brain, which is something which we would like to avoid. And hypertonic fluids usually cause the opposite, that is why they are used more commonly in brain trauma. Next. So when you think about cerebral edema, it largely has three mechanisms. I'll not go into the details. One happens at the level of the cell, what is termed as the cytotoxic edema, where the neurons and astrocytes develop the edema. There is disruption of the mitochondria, ATP gets depleted, and there is a shift of sodium and water towards the cells, into the cells. The next is the edema arising in the blood vessels, or the vasogenic edema. So there is a disruption of the endothelial tight junctions, and again there is both water and albumin shift. And then there is the ionic edema, where there is compensatory solute and water shifts between vascular compartment and interstitium through an intact blood-brain barrier. Next. Now coming to the question which we all want to discuss here, which fluid? So what are the options available? Obviously, we all know that there are crystalloids and there are colloids. So crystalloids are the ubiquitous normal saline, if you call it normal, your ringer lactate or your balanced crystalloids. And then there are the colloids, which are the natural colloids, which is the albumin, and the artificial ones, the gelatins, the dextrans, and the Hess. Next. Now, if you can read this chart, I would just like you to, today's entire discussion this chart is going to help you a lot. Just watch, and we all tend to forget this osmolality values. But if you look at the plasma osmolality, it is 288 with a sodium of 140, a chloride of 103, and a potassium of 4.5. If you look at the normal saline, the osmolality is 308. Look at the sodium, it is 154. And look at the chloride, it is 154 as against 103 of normal plasma. Your ringer lactate has an osmolality of 279, sodium of 130, chloride is 111, and a potassium of 4. And if you go for balanced solutions like plasma light, which is isotonic, it has sodium exactly the same as that of plasma with a lower amount, relatively lower chloride, and a potassium of 5, and so on and so forth. Next. Now, where is the evidence? Let's first talk about colloids. So this I think all three of us are going to talk about this SAFE trial, the most, probably the biggest one, the large multi-center trial, the saline versus albumin fluid evaluation of the SAFE trial. It actually found no difference in 28-day mortality for critically ill patients who are resuscitated with albumin versus saline. And this actually changed a lot of practice. It made us think again. But if you talk about specifically about patients with neurotrauma, this subgroup analysis of say patients actually suggested that there was an increase in number of deaths among patients with traumatic brain injury who received albumin. Next. So based on the results of this SAFE TBI group, they concluded that there is no evidence from RCT in critically ill or traumatic patients that resuscitation with colloids compared to crystalloids actually reduces the risk of death. So that thing is out. Next. So coming to the crystalloids now. We all know that your half NS or 0.45% saline or your 5% glucose in water, as I discussed earlier, causes a concomitant reduction in the osmolality of the plasma, thereby making the patient more prone to cerebral edema. So if you have a patient with head injury and you're giving 5% glucose, I don't think very many people do, but you are definitely increasing the chances of worsening. The osmotic gradient drives water across the blood-brain barrier into the cerebral tissue, increasing the cerebral water content and increasing the ICP. Next. Coming to the hyperosmolar, we all know that a relatively small volume of hypertonic saline, usually we use 3% NS, can actually significantly reduce ICP, correct the cerebral blood flow, and actually improve cerebral oxygen delivery. Hypertonic saline is also known to suppress production of pro-inflammatory cytokines in activated microglia and other things. So in effect, your CNS effects of hypertonic saline are very similar to mannitol. I'm not here to discuss the use of hypertonic saline in reducing cerebral blood flow, but you have to remember that the major problem with hypertonic saline is obviously the chances of developing hypernatremia, or there could, in rare cases, be chances of a rebound intracranial hypertension. Next. So this brings me to the isoosmolar fluids. Isoosmolar, which have the same osmolarity as your plasma. So, which is around 300 milliosmoles per liter. Most commonly used normal saline or your plasma light, which do not actually change the plasma osmolality and do not increase the water content of the brain. Same does not apply to solutions that are not truly isoosmolar with respect to plasma. So your Ringer lactate has a calculated osmolarity of 275, but a measured osmolality of 254. So it indicates an incomplete dissociation. So if you are administering large volumes of Ringer lactate, it might reduce plasma osmolality and increase the brain water content and ICP. So usually it is not a favored fluid and resuscitation in a patient with head injury. Next. So coming to normal saline, we know, as we discussed with our case, if you're giving large volume of NS, commonly there are chances, and large volume means like the one we gave 3 liters, 4 liters. So there might be dilution, hyperchloremic metabolic acidosis, especially if your patient is in shock with impaired kidney function of perfusion. So this predisposes the patient to some extent of worsening of the AKI. So massive infusion of chloride-rich fluids leads to renal ischemia, following interstitial edema, and reduces the GFR following arterial vasoconstriction. Next. So coming to the balanced solution. So isotonic balanced salt solutions are known to reduce the occurrence of dilutional hyperchloremic acidosis, and they do not affect ICP and the number of episodes of intracranial hypertension. Now, there are various studies, despite their different composition. Now, this is another study. It says that it has similar unfavorable effect of plasma light and NaCl. So the jury is still out. Next. Now, this is an interesting study where they studied balanced fluid versus saline-based fluid in post-operative severe traumatic brain injury patients. In 2017, almost 66 patients. Who has this microphone, please? Almost 66 patients were studied with severe traumatic brain injury who required emergency craniotomy. They were divided into two groups, normal saline versus balanced fluid. Maintenance fluid given as per the Holiday-Segar method. Next. And their findings said that normal saline group showed a significantly lower base axis and lower bicarbonate levels. They showed more hyperchloremia and hypokalemia as compared to the balanced fluid group. The balanced fluid group showed a significantly higher level of calcium and magnesium. However, there was no significant difference in patients in both groups in pH, PCO2, lactate, or sodium. So to conclude, the balanced fluid therapy actually showed better effects in maintaining higher electrolyte parameters and reducing the trend towards hyperchloremic metabolic acidosis as compared to normal saline, especially if you're giving large volumes over a prolonged period of time in patients with traumatic brain injury. Now, another study, the balanced crystalloid versus saline for perioperative intravenous fluid administration in children who are undergoing neurosurgery. So these children, especially those undergoing craniotomy for brain tumor resection or saline infusion, resulted in increased serum chloride variation from before to after surgery, obviously. So balanced crystalloids were associated with a safer electrolyte and acid-base profile as compared to saline. Next. Now, the AHA-ASA guidelines for early management in patients with acute ischemic stroke. Daily fluid maintenance for adults estimated at 30 ml per kilogram. Using isotonic fluid, they said, rather than hypotonic fluid was recommended. Hypovolemia should be corrected, they said, with IV normal saline. Next. Now, recommendation about management of cerebral and cerebellar infarction in patients who then had developed swelling. Use of adequate fluid administration with isotonic fluid might be considered class 2B, evidence level C, and hypotonic or hypoosmolar fluids obviously will never be recommended. Next. However, they have not given any specific guidelines in patients with traumatic brain injury. So to summarize, I would say, especially dealing in patients with neuropathology and particularly in patients with neurotrauma, where you don't have much scope for making a mistake. If your patient lands up with shock and you are forced to give huge volumes of fluid, it's a better idea to go in for a balanced solution as compared for normal saline. We are still awaiting large trials. They are on to look at the mortality data, but definitely when it comes to acid, and especially in patients who are highly prone to AKI, it is a better idea to go for balanced fluids. I would stop here. Next. I'm just introducing this. We are organizing, this is the 11th year, we are organizing this mechanical ventilation workshop. Dr. Supradeep would be here, Dr. Devatya, Rahul Pandit, probably most of you know, especially the students who are here. This is a 2-day event, and we've now probably, I will not use the word mastered, but we'll now come across some, we're going to have 1 day complete this time on simulation. So if your students are interested, they might enroll for this. I'll end here, and I think Shrishti can come over, and both our chairpersons are busy. So without taking more time, I think we're running late. I now introduce Dr. Supradeep Ghosh. Dr. Supradeep Ghosh is the Director Critical Care at Fortis Hospital, Faridabad. He is a very sought after teacher, and you'll see his presentation. He loves teaching. Most of his classes, actually, people don't let him stop. And he has some very original work on fluid. He has a book published via Springer. And as I was discussing, it is more popular outside India than in India. So, Dr. Supradeep, all yours. I think we'll have a half an hour of question and answers. So please.
Can I have the slide, please? So I am Supradeep. I have come from Faridabad. I am basically a physician, just like my friend Pankaj, and I love Jaipur. I have been to Jaipur several times, thanks to Pankaj. And I am married to, apart from my wife, to fluids. So I'm passionate about intravenous fluids. So I would like to have a more interactive session. So let's have more interactions. So we'll be discussing some cases and let's see the opinion. In fluids, there is nothing absolute. There is nothing absolute. In a particular patient, in some point of time, this fluid may be important. In another point of time, other fluid may be important. So can I have the slide changer, please? So like in any other drug, when we give fluid also, fluid is a drug. We all agree now, the fluid is a drug. Like any other drug, it has got an indication, it has got contraindication, it has got adverse effects, it has got a dosing, it has got a variety. Like anti-diabetics, we have metformin, we have like sulfonylureas and so many other drugs which have come recently. Similarly, fluid also have colloids, crystalloids, so on and so forth. Okay. So when we choose a fluid, like any other drug, we choose the fluid based on two basic principles. First principle is the choosing the appropriate fluid. And when we choose the appropriate fluid, we take into consideration three things: efficacy of the particular drug, the particular fluid, the safety of the particular fluid. Some of the safety concern has been mentioned by Pankaj in his previous talk, and of course the cost. At the same time, we also look into take into consideration the complications. We want to avoid the complications. The biggest complications is the fluid overload. Apart from the fluid overload, we have dyselectrolytemia. Pankaj has mentioned a bit about the problems with saline. We have acid-base disturbances, and we have worsening of the organ dysfunction. Certain fluid can actually worsen an acute kidney injury and so on. So these are the things we take into consideration. Beta ye chal to nahi raha hai aapka. Something is wrong. Aap change kar do apne se. So Pankaj has mentioned, so we have for resuscitation purposes, we have two different types of fluids. In one hand, we have the colloids. Some of my anesthesia colleagues are still fond of some of the colloids. I am fond of albumin. So there are roles of colloids. Now, what are these colloids? Colloids are the substances which are non-soluble substances which are suspended in crystalline solution. So these are the colloids. The colloids can be synthetic, like hydroxyethyl starch, dextrans, or gelatins. Gelatins can be again succinylated or urealated. And we have natural colloids like albumin. Now, albumin again is available in hypotonic, isotonic solution, like 4%, 4.5%, 5% albumin, or we have hyperoncotic albumin like 20% albumin and 25% albumin. Apart from that, we have the crystalloids. These are the crux of the most important fluid which are being used in day-to-day practice. Crystalloids can again be for resuscitation purposes, it can be isotonic or it can be hypertonic. Isotonic we have again divided into balanced fluid which are closer to the plasma. Plus, please don't remember, none of these fluids are ideal. None of them. None of the commercially available fluids are ideal. But Balanced fluid solutions are closer to plasma because their electrolyte compositions are closer to plasma. For example, normally in our body, the potassium is between 3.5 to 4.5. So these balanced solutions contains around 4 or 5 milliequivalent per liter of, so they are closer to the plasma. And we have the grand old 0.9% saline, whether you call it normal saline or abnormal saline, but they are there. So out of the balanced solutions, we have different ones like ringer lactate, we have cabilite, we have maybe plasmalite or cabilite. We have stereofundins, we have ringer's acetate, which is not available in Indian scenario. So we have so many of the drugs available for us to use. Now, which one to choose from? Aage badha beta. So let's go for the case. I want everyone to participate. So let's see a case. These are the very commonly used case. 74-year-old male diabetic with nephropathy presented with evidence of pneumonia and septic shock, right? His ABG showed a pH of 7.36. Students, do you agree that this patient has a septic shock? His blood pressure is 104/56, but I still say he is in septic shock because the lactates are elevated and the CRT, the capillary refill time, is elevated, which is not mentioned here. Lactate is 4.6 millimole per liter. So even if the blood pressure is normal, blood pressure is maintaining with some compensatory response, but he is in septic shock. ABG is 7.36, PO2 64 on 4 liters of oxygen, PSCO2 is 32.8, and his bicarb is 19.2 millimole per liter. So we have a patient, elderly male, diabetic with nephropathy in septic shock. Now you want to give fluid. So which one should be our aage badhao beta. So ED physician decides to give some fluid. So what do you want to give? 2 liters of isotonic crystalloid, 500 ml of isotonic crystalloid, 500 ml of 5% albumin, 500 ml of hydroxyethyl starch, the grand old hydroxyethyl starch, volulite. 2 liters of isotonic fluid. Anybody in favor of that? 500 ml of isotonic fluid. Now I am not going to balanced or something. I'm going to only isotonic fluid. You are in favor of 500 ml isotonic. Anybody in favor of 5% albumin? You are in favor of 5%. Great, ma'am. Anybody in favor of volumen? No? No one? No. You are in favor? Oh, sorry. So let's see the evidence. The big colloid versus crystalloid debate. The only study which has compared, randomized control trial, which has compared all colloids versus all crystalloids was the crystal study, which was done over a period of more than 10 years in various countries, including North African countries and mostly France. And this study, they compared all colloids, as I said, like including HAS, albumin, gelatin, versus all crystalloids, including saline, ringers, or whatever, all, including hypertonic saline. And outcome was, there was no difference in 28-day mortality. So there was no added advantage of colloid, which was perceived. We perceive, as being the traditional thinkers in our generation, that colloid will remain in the intravascular compartment for a long period of time. But unfortunately, it doesn't occur like this. It also pushes out of the intravascular fluid and it goes to the interstitial compartment and actually increases the edema in the interstitial compartment. So they did not find any overall advantage of colloids, all colloids over all crystalloids. So we have many studies on hydroxyethyl starch. And the crux of all these studies, I have just quoted 3 of them, the bicep, the 6S, and the chest, which was published in different period of time on different hydroxyethyl starch composition. And overall, they found that there was a trend towards increased mortality. In fact, the 6S trial has shown a trend towards increased mortality in the hydroxyethyl starch group. And definitely all the 3 trials have shown the hydroxyethyl starch increases the incidence of acute kidney injury. incidence of requirement for renal replacement therapy, increase the coagulopathy. We know from the physiology, they increase the coagulopathy, increase the requirement of blood and blood products in the hydroxyethyl starch. So colloids overall doesn't have much advantage. Hydroxyethyl starch per se may be dangerous, especially in patients with septic shock. We don't have much data in the perioperative period as such. And we all know the hydroxyethyl starch is much, much costlier than our good old isotonic crystalloids. What about albumin? Pankaj has mentioned about the SAFE trial. Anybody who wants to practice critical care must read the book, this particular trial. 7,000 patients were included, where 4% albumin were compared to 0.9% saline as a resuscitation fluid, and they did not find any worse outcome with albumin. This trial was necessary because of one study which was published 3 years prior in Cochrane Review, which showed that albumin increases the mortality. So it was necessary that to do this randomized control trial, and they did the randomized control. They found that albumin is safe, but they did not find any added advantage of albumin overall compared to the 0.9% saline. And we all know albumin is costlier. So overall, I feel no clinically significant advantage of hydroxyethyl starch or other colloids over isotonic fluids. We all know the hydroxyethyl starch is potentially harmful, including the increase in the incidence of acute kidney injury, renal replacement therapy, coagulopathy, allergic reactions, so on and so forth. Smaller studies have shown that even other semi-synthetic colloids also have got the similar type of adverse consequences, including gelatin and dextran. And we all know that colloids are costlier. So why shall I use colloids in this, my patient of this? So I don't think there is any iota of doubt regarding not using colloids in resuscitation of septic shock patients, except in specific circumstances. We'll discuss about that. So overall, in this patient, I would like to not give colloids. I hope now I could convince you all. What about the rate? I mentioned about 2 liters and 500 ml. Why this 2 liter came? The 2 liter came into existence because of this fantastic guideline called surviving sepsis guideline. I don't know whether this guideline should be in place or not now. It has served its purpose. What do you think, Kishore? It has served its purpose. So we should be now vanished. So this guideline suggests every patient of septic shock should receive 30 ml per kg body weight in the first 3 hours of resuscitation. That's the reason I given 2000 ml. Like in an average in Indian male or female is 60 to 70 kg. So if you 30 ml per kg body weight, you have to give 2.1 liters of fluid or 2 liters of fluid. Though there is no rationale behind this particular guideline. If you go for the students, whenever you read guidelines, please see the evidence behind these guidelines. It can be just a statement, some expert opinion. You need to read the evidence behind it. Whether it is based on some strong evidence or it is just an opinion. So this is actually an opinion, 30 ml per kg body weight. There is no rationale behind it. Now tell me one thing. We have a patient who is in pneumonia with pre-existing dilated cardiomyopathy and septic shock. And we have a patient with cholera and septic shock. Do you think both of them will receive 30 ml per kg body weight? Do you agree? It's not possible. So we need to look into see the context. At what context you are giving what, right? So 30 ml probably has not. Now what we have, probably the best evidence still lies with the original description of Sir Thomas Latta. Sir Thomas Latta has provided the first description of using intravenous fluid, published in Lancet back in 1832. None of us were born that time. And he wrote, having no precedence to guide me, I injected 1 ounce after ounce of fluid, closely observing the patient. Thus, probably the only valid thing still now is give fluid a little bit and see how much is the effect. And what should be the little bit? That little bit should be at least 4 ml per kg body weight. Why this 4 ml per kg body weight? This has come from a pharmacodynamic study by this group from Imperial College, by this Holman H. Aya and team. And this found that minimal volume required to expand the mean systemic filling pressure is 4 ml per kg body weight. So instead of giving 2 liters, probably 4 ml per kg body weight, something around 250 ml or 300 ml or 500 ml probably is good, and see whether the effect is there or not. As I said, dose also should be guided by the patient's phenotype, and further fluid volume should always be guided by fluid responsiveness. We'll come to that. So my conclusion for the first question is patient should receive maybe 250 to 500 ml of isotonic crystalloid. Now I have not come to the question which isotonic crystalloid. Let's go to the next case. Sunny boy. Okay, let's see this 98-year-old male. 98-year, grand old. 98-year-old male, dementia, hypertension. This is the type of patients we routinely see these days in ICU. You know, 80, 50, they are all okay. They're good. They want to live more. 98-year-old male, dementia, hypertension, old CVA, chronic AF, poor mobility. He presented to us with poor oral intake for 10 to 12 days and some low-grade fever for 5 days, which probably was not noticed by the daughter-in-law. And gradual worsening of sensorium, which was noticed by the daughter-in-law. She noticed that 3 days, for last 3 days, Baba nahi le rahe kuch. And he is actually unresponsive since morning, so they got him here. On examination, he had GCS of U1, M2, B2. Extremities were cold, mottled skin. Mottling is an indicator for shock, mottling, the discoloration of the skin. BP not recordable, respiratory rate was 32, labored, neck supple, all these things. So we suspected it's an urosepsis or maybe an pneumonia, but urosepsis was the things. ABG showed a pH of 7.15, PaCO2 of 62, base excess of -16, and a lactate of 8.4 millimole per liter. So what should be the most appropriate step in the resuscitation of such patient? Though it's a fluid management things, but fluid and vasopressors are closely related. So shall we start norepinephrine infusion immediately? Shall we give fluid first? Once the fluid is over, then start the norepinephrine, or shall we start both simultaneously? Who is for one? Anybody from one? We'll start norepinephrine immediately. Anybody for two? Anybody for three? You are for two, ma'am. You are also for two. Who is for three? You are for three. And my friend Kushori is also for three. Huh? So three. Now, what is the rationale? Let's see. Why vasopressor? See, we cannot give fluid only. Fluid and vasopressors go simultaneously, hand in hand. And why? We have enough evidence. Especially, I would like to emphasize for youngsters, diastolic blood pressure. Diastolic blood pressure is the one which maintains the perfusion of heart, right? So we need to maintain a diastolic pressure of at least 45 to 50 millimeter of mercury. Apart from diastolic blood pressure, they have seen in patients of postpartum hemorrhage who are otherwise healthy young females. Postpartum hemorrhage patients, even with a systolic blood pressure of less than 80 or diastolic pressure of less than 50, the coronary cardiac damage starts occurring. The tropi increases. So maintaining a low diastolic blood pressure or a very low mean arterial pressure is detrimental to the patient. Second important thing for starting an early norepinephrine in such patient is norepinephrine also causes venoconstriction. In patients with vasodilatory shock, if you produce venoconstriction, that will increase your venous return by increasing the mean systemic filling pressure. Okay. And third thing, studies have shown if you start norepinephrine early in such patients, you reduce the overall fluid. Now we are talking about fluid restriction, overall cumulative fluid volume in the long run. So that's the reason you go for it. Beta, aage badha lo. So I would like to go for 3. So this patient BP is not recordable. If you want to sustain him, we need to start norepinephrine. At the same time, if he is relatively hypovolemic, or since he was not taking orally, so he is absolutely hypovolemic, so we need to start IV fluid also. So what happens normally? Well, while you prepare the norepinephrine, you start the IV fluid. You start the IV bore cannula, large cannula, and start the IV fluid. Simultaneously, you ask the staff to prepare the norepinephrine infusion. That's what we do. And we need to do both the things simultaneously. So let's see the case scenario 3. Now, so far we are talking about the norepinephrine, vasopressin कब start करना, vasopressors कब start करना, and whether to give colloid, whether to give crystalloid, and how much colloid or how much crystalloid. Now we are coming to which of the isotonic fluid. So he is a 36-year-old male, no comorbidity, admitted to the ICU with severe dehydration following cholera. So last season, Pankaj, we have seen 30 cases of cholera in our ICU, including and one fine day, mayor of Faridabad also was admitted. No, this was a long case, ma'am, long back. But last year we have seen 30 cases of cholera. We are maintaining fantastic hygiene. So ABG showed a pH of 7.41, PaCO2 of 32, bicarb of 19, FeO2 of 82 on room air. So this is the plan. Plan is to obviously cholera, the fluid, and fluid. It loses 6 to 12 liters of fluid. We have to give fluid, large volume of fluid. Now plan is to start isotonic crystalloid. Now which one? Now we have option 1, 0.9% saline, and option 2, balanced salt solution. Which one? Who is for saline and which for balanced salt solution? So, though balanced. Sodium is 132. So, आप क्या start करोगे, ma'am? Okay, potassium 2.7. आप बता दो मैम, मैं बना दूंगा, ये तो बना लूंगा, मैं ना, I have to cook the story. Yeah, balanced. Okay. So let's see the evidence. Pankaj has briefly introduced the topic, and we know this fluid. Pankaj has shown this slide, and so we need to see few things. Sodium content of 0.9% saline is high compared to the balanced salt solution, but all balanced salt solutions are not same. There are different things. I have not specifically excluded Ringer's acetate because it is not available in India. Potassium content is 0 in 0.9% saline, and there is a concept that 0.9% saline will be beneficial in patients where there is a hyperkalemia. I'll talk to that in the few minutes time. Calcium is another things. Some of the balanced salt solutions like Ringer lactate and styrofundins contains calcium, whereas Cabilite doesn't contain, or saline does not contain calcium. Look at the buffer content of these solutions, the buffers. In Ringer's lactate, the buffer is only lactate, okay? And lactate is metabolized to bicarbonate. Whereas in Cabilite and in styrofundin, the main buffer substance is acetate. So that's the difference, there's a catch. Lactate, the gluconate and maleate found in styrofundin and Cabilite, their metabolism is either not there. For example, gluconate is usually not metabolized in the body, and maleate metabolism ke bare mein we do not know anything. So we are more interested in the lactate content and the acetate content. So this is just the introduction. And importantly, Pankaj has already mentioned the chloride content of these solutions are very, very high in 0.9% saline. Aage badhao beta. And what happens if the chloride content is high? If the chloride content is high, the chloride goes to the macula densa, and body senses it as hypervolemia, and that produces constriction of the afferent arteriole, vasoconstriction, and that produces possible renal damage, which we call tubuloglomerular feedback. That is probably the pathophysiology behind hyperchloremia induced renal injury. And is it true? Is it true? So this is the volunteer study, very old study by Dr. Chaudhary, published in surgery, the American Journal of Surgery or some surgery, whatever. And they found that normal saline compared to plasma light is like some same as KB light, is produces hyperkalemia, decreases the strong ion difference. I'll come to the strong ion difference, increase the extracellular volume, and it decreases the renal artery flow, and it also decreases the renal cortical perfusion. So this is probably the mechanism behind possible renal injury with 0.9% saline. What is strong ion difference? So strong ion difference is nothing but the difference between all the cations and all the anions, all the particularly soluble cations and soluble anions. In our body, the most important soluble cation is what? Sodium. And what is the most important soluble anion? Chloride. So difference between sodium and chloride is the most important thing. What is the normal difference between sodium and chloride? 40. 140 sodium and 100 is the chloride, 40. So if you have any balanced salt solution, any solution, आगे बढ़ा, any solution which has a SID, strong ion difference, the content between sodium and chloride, if the strong ion difference of that particular solution is more than the bicarbonate of the patient, it will produce metabolic alkalosis. If it is less than the bicarbonate of the patient, it will produce metabolic acidosis. Since the strong ion difference of normal saline is 0, sodium is 154, chloride is 154, minus is 0. So it will always produce metabolic alkalosis. But in the balanced salt solution, sometimes it can produce metabolic acidosis, but in most of the times it will produce metabolic alkalosis because strong ion difference is very high. So do we have data, saline versus balanced solution? They found in the observational study, a large observational study, I have quoted one of them, that if you give too much of saline, it is directly related to mortality of the patient. Directly related to the mortality of the patient. And this risk of mortality increases with the dose, the cumulative dose. Higher the cumulative dose of saline given, higher is the chance of mortality. But remember, this is from observational study. What about before and after study? This is a study very widely quoted by Yunus et al. And they have done one more study of the similar line, where they found that if you, in one control period, they gave only high chloride solution. For example, saline, 0.9% saline, gelatin, some hydroxyethyl starch, older generation like Voluben. So these were given in one thing, and the in the intervention period, they reduced all chloride containing solution. Instead of saline, they introduced isotonic balanced solutions. They introduced low salt albumin, and they found in the intervention period, when the chloride containing solutions were reduced, there was a significant decrease in the rise in creatinine, rise in AKI incidences. So they could find there is an association again. If you reduce the chloride containing solution, we can have a better chance of renal safety. Based on these, multiple randomized control trials were published. कुछ तो अभी भी निकला है, 2022 में निकला है कोई, plus there is some solution 2021 में निकला कोई basics. It all started with split, and actually they are not conclusive. Why they are not conclusive? Because they have not given large amount of fluid at all. Average fluid given is 1 to 1.5 liters. You don't expect much with that. So in conclusion, so what is my conclusion from so far is, in majority of the patient, 0.9% saline should not be preferred because it is associated clearly from physiological data. It is associated with hyperchloremic metabolic acidosis. It has got a potential for renal injury. I have explained the reason behind it. Sodium overload, it is obvious you are giving 154 millimole per liter of sodium. And obviously when you give sodium, sodium will retain more fluid. So in patients with ADHF, the acute decompensated heart failure, or patients with AKI, this can be more detrimental. And there is a potential increase in mortality, as has been shown in many observational studies, as I have just shown you. However, it's not that 0.9% saline should be out of the box. No, there are some indications for 0.9% saline, as Pankaj has shown in the traumatic brain injury. Because of the osmolality, 0.9% saline may still be used. Or any other patients with raised ICP. What about patients with hypovolemic hyponatremia? We do see patients, especially in the pediatric age group. Hypovolemic hyponatremia, the drug of choice is 0.9% saline. There is no doubt about it. So we just cannot throw it in the dustbin. No? What about hypovolemia post-vomiting? Remember, after vomiting, what happens? Multiple episodes of vomiting, food poisoning, multiple episodes of. If you vomit, it produces a metabolic alkalosis. If a patient has got a metabolic alkalosis with hypovolemia, the drug of choice again is saline. Because if you give balanced salt solution, it will produce further metabolic alkalosis. And I was posted in Andaman and Nicobar Island as a naval officer. And unfortunately, most of the time, we did not have any other fluid apart from 0.9% saline. And this is the scenario in many of the places across the world where you do not have anything. Balanced के लिए इंतजार थोड़ी कर सकते थे, तब तो यही देंगे 0.9%. So it was a long discussion. So Cox's, most of the cases में we should give balanced salt solution. Now let's see this. A 68-year-old male, no comorbidity, road traffic accident, rushed to the ED of a nearby hospital. There was a low GCS, abdomen was distended, first shows free fluid, fracture ribs, fracture femur, 2 large bore cannula, norepinephrine infusion, massive transfusion protocol. We all started this. And decision was taken to infuse IV fluid. Pankaj has gone through this particular case, so I'll just go through quickly. So which fluid? 1 liter of saline, 500 ml of 6% hydroxyethyl starch, 500 ml of 5% albumin, 1 liter of Ringer's lactate. Fast. So I will quickly rush through it. Okay. So this was the safe study subgroup analysis, which was done. And clearly the subgroup, only one subgroup has shown a very clear things that ये तो चल पड़ा बेटा अचानक से एक ही subgroup है, only one subgroup. In the trauma subgroup, patients in the saline group did better. In the trauma subgroup. So they continued the study, as Pankaj had mentioned, called the SAFE TBI study. They followed this patient for 2 years. Same patient, this subgroup, and they could find the Glasgow outcome scale at 6 months, and 6 months and 24 months, both were better with saline. So it is, and why it is so? Obviously, the blood-brain barrier is disrupted. So there is a more chance this albumin is going to the interstitial compartment and producing more edema to the brain. So this is probably the reason for worse outcome with albumin in such patients. And we can definitely extrapolate the same data for other colloids too. We cannot give colloids in this. So colloid is out in TBI. And Pankaj mentioned about the osmolality. So I'd like to ask, tell you 2 things. There are 2 osmolality. One is absolute, the calculated osmolality, which we calculated from the particles, number of sodium kitna hai, chloride kitna hai. And another is called effective osmolality. Effective osmolality is the osmolality in body temperature. And what we are interested is the effective osmolality. And see the effective, and what is the effective osmolality of body? 285 to 295, right? So we need to see, so we have to select a solution which has got an effective osmolality between 285 to 295 to avoid cerebral edema. Okay? Okay, 56-year-old, I have, because people cannot tell me a gender bias, so this time she's a female, okay? 56-year-old female, diabetic, admitted with urosepsis and septic shock. Ultrasound showed left hydronephrosis. She is drowsy. Obviously she is in septic shock. She has got a blood urea nitrogen of 112, serum creatinine of 5.65, potassium of 5.53, sodium of 137. Which isotonic fluid? 0.9% saline or balanced salt solution? Who is for saline? And Anybody for saline? Bezhijak. 2. Ma'am, potassium is 5.53. पोटेशियम, तो आप क्या देना चाहोगे? सलाइन. ओके, आप क्या देना चाहोगे? नहीं मैम, कोई थर्ड चॉइस देना ही नहीं है ना मुझे. तो मजा ही खत्म हो जाएगा. Yes ma'am, creatinine is high because patient is in septic shock and hydronephrosis है. Saline safer. Anybody has got different opinion? Well, this is a very important issue. You know, I find a lot of my nephrology colleagues are very much worried about giving balanced salt solution because they feel their saline is safe. Okay. So this is a myth. This is an absolute myth. The saline is safe in hyperchloremia. This is a myth. Myth is, and there is a myth, another myth is the basic, because this balanced salt solution contains 4 to 5 milliequivalent per liter of potassium, it will cause hyperkalemia. It doesn't happen like this. Rapid dilution of potassium content of the balanced salt solution will not give rise to rise in hyperkalemia. And second thing, what we have seen, the balanced fluids have got high SID. Strong ion difference of balanced fluids are high. If the balanced solution have got high SID, it will produce metabolic alkalosis. And metabolic alkalosis will shift the extracellular potassium to the intracellular compartment. Rather, it will produce hypokalemia. Whereas saline, it produces metabolic acidosis. We all agree? And metabolic acidosis will shift the intracellular potassium extracellularly. Now, is it just a perception, or do we have data? We have data to show this. There are 3 randomized control trials done on renal kidney transplant patients where saline was compared to ringal lactate, which is a balanced salt solution, and they found actually it is the saline which produces more hyperkalemia compared to ringal lactate. And at least one of the studies have shown ringal lactate rather produces hypokalemia. So this is a myth. आगे बढ़ाओ बेटा. Let's see this patient. 2 reasons. Balanced salt solution produces metabolic alkalosis. Metabolic alkalosis will shift the extracellular potassium intracellularly. So this is one reason, and it is exactly the other way around for saline. Saline will shift the intracellular fluid intracellular potassium extracellularly, so because it produces metabolic acid. The other reason is more plausible reason is because it's the 4 or 5 milliequivalent potassium is a minuscule quantity. When it is given rapidly in the extracellular compartment, in the intravascular compartment, it disseminates rapidly and it cannot give rise to a hyperkalemia. That's not possible. Okay, 1 minute. 42-year-old male, chronic liver disease, child PU class C, increasing ascites. Basically, patient of, what I wanted to say is it's a patient of spontaneous bacterial peritonitis in an advanced chronic liver disease patient. Child PU class C is an advanced chronic liver disease. And he has got metabolic acidosis. Obviously, he's in septic shock. Now, what should be the best fluid in such patient? Shall we give 0.9% saline? Shall we give ringal lactate, or shall we give Kebilite? Arun is for 3. Arun is for 3. Anyone, any option? Young men and young girls? Who is for Kebilite? A reason? मैंने 3 मेंशन किया. मैम बेस्ट ज्यादा चॉइस नहीं दे रहा हूँ आपको, क्योंकि नहीं तो आप और कुछ सोचने लगोगे. नहीं, डाटा नहीं करेंगे ना, इतना ही रखना है बस. मल्टीपल चॉइस, सलाइन, केबिलाइट और रिंगल लैक्टेट. Okay. So here is the importance of the buffer. Okay, here is the importance of the buffer. The lactate is metabolized exclusively in the liver. So in a patient who has got a Child-Pugh class C in septic shock, though we do not have solid randomized control evidence, but at least physiological evidence that there is a less possibility, at least when you give a large volume of ringer lactate, not 500 ml, maybe 2 liters, 2.5 liters. You give a large volume of ringer lactate, the lactate may not get metabolized. Okay, so that is the problem. Whereas acetate is metabolized in every tissue of the body. So there is a theoretical possibility, at least, that acetate containing fluids will be advisable in such patients. It's a theoretical procedure. I do not have any strong evidence from randomized data. Okay. 56-year-old male, pneumonia with septic shock. I'm coming to the conclusion in a few minutes. So started on norepinephrine, something like antibiotics are given. He's basically pneumonia with septic shock, mechanically ventilated. Heart rate is 120 per minute. Some 1.5 liters of fluid has already been given. The patient is still in shock. What do you want to do? Do you want to give fluid straight away, more fluid? Patient is already on norepinephrine and vasopressin. Do you want to do something else for the youngsters? Patient है pneumonia, septic shock, 1.5 लीटर फ्लूइड दे दिए हैं, नॉरेपी चल रहा है, vasopressin चल रहा है, अभी भी शॉक में है. What do you do now? सोर्स कंट्रोल निमोनिया में बेटा एंटीबायोटिक ही दे सकते हो, लंग नहीं निकालेंगे ना, और कुछ कर सकते हो. हाँ हाँ जी मैम, आगे बढ़ाओ. चलो मैम बता दिया सीवीपी और आपके हिसाब से 4 लगा दिया. So basically you are in the right so do not give fluid blindly in such patient. Such patient we need to perform some test to see whether our patient will improve with further fluid, because fluid is not without harm. Further fluid may be harmful to this patient. So whenever we want to give fluid in such patients, follow some fluid responsive parameters. Now we have different types of fluid responsiveness parameters. Some are called static fluid parameter, static fluid responsiveness parameter like CVP, which are probably not the best, probably should not be used. And we have the dynamic parameters. So we have a list, we need to follow it. It's not a hemodynamic monitoring class. So the crux is we need to use some fluid responsiveness parameter before giving fluid. So my last case, 25-year-old female, some vasculitic disorder, multiple jejunal ileal perforation. Postoperative day 7, the patient is oliguric. Postoperative day 7, patient is oliguric. Urine output is 15 to 20 ml per hour for past 3 hours. Heart rate is 112, MAP is 68, on low dose norepinephrine support. SpO2 is 94%, she is on MB, mechanical ventilation with FiO2 of 0.6. Hemoglobin 8.2, creatinine 1.4, lactate 3.2, cumulative fluid balance so far in 7 days is 16,500 ml, 16 liters. What shall we do? क्या करें? आगे बढ़ो बेटा. Shall we give further fluid to this patient? अभी भी नॉरेपी चल रहा है, यूरिन नहीं आ रहा है, क्या करें? और पानी चढ़ाएं? Shall we increase the dose of vasopressor? Shall we diurese the patient, or we are not sure? We need more data. Fourth answer is easy to give. So here I just wanted to emphasize on the fact that fluid overload is dangerous. This patient, we are giving more data. This patient, we did a intra-abdominal pressure, and we could find this intra-abdominal pressure was very high. I don't remember, it's an old case, very high intra-abdominal pressure. And this intra-abdominal pressure was produced both by the post-operative status and by the fluid we are giving. giving further fluid to this patient is harmful. So rather, we need to remove the fluid. So many studies have shown that fluid overload is bad. Fluid overload is bad. And this is bad because of this. Many of you, if you go to the Google, then you will find this photograph. This is a very known photograph. Michelin tire ka ad hai. जिसमें my good friend Manu Malbrain has just made some for this thing, and he has coined this term called global increased permeability syndrome. Basically, if you have a fluid overload, fluid gets extravasated to different compartments of the body, and that produces dysfunction of every organ system, whether it is from brain, whether it is kidney, whether it is lung, whether it is skin. Sometimes we see the edema, sometimes we do not see the edema. Sometimes we say that if there is a edema, it's just a cosmetic thing. No, it is not cosmetic. If there is a pedal edema or edema in the sacrum, presacral region, it means the patient has also got edema in organ systems. So this is harmful. So we need to measure. So it's called global. This is not my slide. I'm thankful to Professor Malbrain. So it is important to limit our cumulative fluid balance. So just to conclude my talk, avoid large fluid boluses, especially in patients with acute decompensated heart failure and patients with acute kidney injury. A small bolus of 4 ml per kg is probably a reasonable volume, and see the response to the patient. Early initiation of vasopressors, like particularly norepinephrine, especially in patients with distributive shock. Youngsters, distributive shocks are like septic shock, like anaphylaxis, like neurogenic shock. These are distributive shock. They improve the cardiac output by increasing the venous return. It is also reasonable to initiate it if the diastolic blood pressure is very, very low. Always assess fluid responsiveness before giving further fluid bolus after the initial fluid therapy. Hyperoncotic albumin has got a role. So when you have already given maybe 2 liters, 2.5 liters of fluid, and you still need to give fluid, then probably there is a role for hyperoncotic albumin. So there is a study called SWIPE study, which was published by the Australian group. They did give 25% or 20% albumin in such patients in small boluses, not in 100 ml 4 ghanta pe de rahe. No, it's in bolus. We do give, and they found that if you give in selected patients hyperoncotic albumin in boluses, you can reduce overall cumulative fluid volume and limit the maintenance fluid and fluid creep. There is a tendency of giving maintenance fluid and forget it. The IV fluid chal raha hai, some DNS, 150 ml per hour, 200 ml per hour. These are detrimental practices. This should be avoided. Patients should be started on enteral feeding as early as possible, and stop the intravenous fluid altogether. And what is fluid creep, youngsters? We often forget how much fluid we are giving in the infusions. Norepi, vasopressin, so many so, midazolam infusion, they are all in fluid. We often forget how much we are giving in the when you ABP line and CVP line, you give some amount of fluid. Flushing, you use saline for the flushing. So we often forget, and we often forget how much we are using for as a diluent. See, especially the antibiotic, we often forget that. This, we tell linezolid 600 milligram BD de dena. This linezolid IV 300 ml BD, you are giving 600 ml of fluid, and plus this patient is receiving some polymyxin B de dena, some 7.5 million unit 12, 7.5 lakh unit 12 hourly. That also contains 500 ml plus 500 ml. So you see, 1.6 liters of fluid you are giving through and you are not calculating that. So these fluids are termed as fluid creep by a paper by Neil van Roggenmartel from Belgium, and they coined this term called fluid creep, where we actually do not calculate this. This particular term, fluid creep, came from burn resuscitation. Okay. So thank you very much. I am ready to take any questions after the session. Thank you.
Thank you, Dr. Supradeep. There could not have been a better way to make us understand all these nuances. Finally, the final talk today. I'm really very thankful to Dr. Achin Narang. He missed his flight from Chandigarh. And can you believe him? From the airport, he took a cab and he's rushed here. So Dr. Achin is here to give his talk. And I've asked him to summarize the entire topic. Dr. Achin, please. He is the director of Alchemist Hospital, Critical Care at Alchemist Hospital, Chandigarh, Panchkula.
Thank you so much, Dr. Pankaj, and I am really thankful to Forum of ACE to hold this meeting. And we can hear, my job here is today to just conclude the fluid therapy in a way that we can practically use it. When a fluid's mostly required is, there are many indications, but the importance lies when it is about resuscitating a patient. They are the saviors actually, even if it is sepsis, it's trauma, it's not the antibiotics. The lifesavers in pharmacotherapy, if it is anything till today, last maybe 200 years, it's the IV fluids. So how to use, and when to stop. Dr. Supradeep has beautifully discussed all this in his case scenarios. I'll just be trying to sum it up that how can we achieve a balance while we are prescribing IV fluids. And to go ahead, is this working now? Okay, so even if I'm just concluding, I still love to always bring up this slide. I don't know how many of you are aware when was normal saline first used. It was discovered in 1800, more than 200 years ago. And it was not intended to be used as a pharmacotherapy. It was discovered in lab experiments because they found that saline do not lyse red blood cells. But later, in cholera pandemic or epidemic back then in 1831, it was first used by Dr. Shaughnessy in patients to resuscitate them, those who were dying of dehydration and shock. Back then, though the term probably shock even did not exist then. Still, it was used and they were able to save many patients. And later, these were propagated by Dr. Thomas Lata, who widely used and spread the word about saline being a savior. Not working. So we want to achieve a balance in our fluid therapy. We need to understand the physiology of fluids, and not just fluids, but the electrolytes which are associated with them. Balance cannot be achieved with either one. 5% dextrose were developed with the same intention that only fluid can be given. But then we all know it did not hold true because electrolytes were equally important. And it took us almost 200 years to realize that we do need electrolytes to be balanced to maintain internal milieu, which will be beneficial for our human systems. So we also need to understand what kind of injury or what kind of patient we are dealing with, whether it's a burns patient, it's a trauma patient, it's a septic patient. Resuscitation differs in most of them, but broadly the principles remain same. So we'll try to know about the properties of IV fluids, and we'll try to know what are the problems we are creating by prescribing them, and we'll be proceeding ahead. Broadly, these are the 5 R's for which we need fluids, right? Indications can be many. So most important, as I already mentioned, is resuscitation because it is life-saving. And then we come up to routine maintenance, replacement therapies. Have to consider for redistribution, especially in situations where there is increased third space lossing like burns or peritonitis. And then reassess, as Dr. Supradeep stressed upon, whether we really need to give more or we need to hold back. And I tell you, that is the question. which actually influence the outcomes ultimately. Just resuscitating in first 24 to 48 hours and saying I have saved the patient. No, we have to move him out of critical care unit. We have to give him back his normal life. We have to rehabilitate him, and that's where the reassessment is most important. So it's time now for fluid stewardship, as we have heard about antibiotic stewardships, antifungal stewardships. What is stewardship basically? It's nothing. It's using anything judiciously. So when we at least have that thought process in mind that I want to prescribe this judiciously, that's where the stewardship role comes in. And this has to be taken into consideration with the both what's the drug. Fluid is a drug. What's the drug? How much do I want to give it, or how long do I want to give it, and when am I gonna stop it in the form of de-escalation? And this has to be considered in every phase. By phases, we mean when we prescribe IV fluids, there are phases like I already mentioned in the indication. There's a phase of resuscitation first, then there's a phase of optimization and stabilization, and then finally evacuation. The focus has shifted, especially we were taught maybe not long ago, even 5-6 years back, I think when Rivers mentioned about early goal-directed therapy, everybody was like, give fluids in first 2 days and patient will be saved. No, that doesn't hold true. We'll be looking at that aspect in the coming slides. Brother, you have to look at me. So it's a dynamic process, and keep moving. So as I already said, first thing is about rescuing a patient or saving a life, which is most important. Then this phase usually is 24 hours. If we can resuscitate well, we'll have the next phases. Otherwise, we'll just lose out right here. So saving a patient, you will probably need large volumes here for resuscitation. What to use has already been discussed. I'll be also going in some depth into it. But first 24 hours, do not hesitate. If the clinical condition of the patient permits, it doesn't hold true for every patient. It cannot hold true for a patient with an ejection fraction of 18 to 20%, who's a DCMP patient. You have to assess that patient or reassess even within first 24 hours. It cannot hold true for many other situations. But if I quote an example, other requirements of fluids for a burns patient and a pneumonia patient will be same, given both are in shock, as blood gases show base deficits and increased lactates, but still volumes required will be different. So what I want to stress upon here is every patient will be different, but the resuscitation phase is going to be the same. So we have to start thinking about volumes, though we usually do not hold back in first 24 hours, because here saving a life, and it's like buying time. We'll have the flow phase only if we survive the ebb phase. So we have to make the patient who comes in a sick situation survive here, so that we can work upon later and streamline his therapies. So that's our optimization and stabilization phase, which lasts for next 2 to 3 days. We may not be requiring that high volumes, some amount of balance if we have already ascertained stabilization or rescuing of patient in first 24 hours. But this is the most difficult phase, I tell you, because here lies the whole confusion. Where to stop? Easy to say. Next, easy to say, de-escalate करेंगे, जल्दी से जल्दी करेंगे, लेकिन कब? क्या patient stabilize हुआ? क्या patient actually is good enough that we can hold fluids for him? If it's a surgical case, can we really hold fluids? No, we cannot. We cannot. So this is the phase. Optimization phase is the phase where we need to consider how much maintenance. This is the tricky question usually, because that will decide whether after 72 hours or after 96 hours, we can start de-resuscitation or de-escalation or not. So Once you have saved the patient in first 24 hours, be cautious. Do not relax with the fluid management. Koi nahi chalne do. The patient is out of danger. Blood pressure is stabilized. No, we have not sent him out yet. We're still dealing with these complications. So we need to be very careful at this stage. So that's all about balancing the fluid therapy. As I already mentioned, when EGDT was propagated, we all were like, told, give fluids, give fluids. There is no harm in giving fluids. Patient should be resuscitated. But then later, we incorporated it even as a resuscitation bundle in surviving sepsis campaign. And it was a teaching for all the students, even for us. We were convinced by the then data that yes, fluids are not bad. But then a lot of trials, especially these three, the PROCESS, ARISE, and PROMISE trials, while reporting on all-time low sepsis mortality, they showed there was no improvement in outcomes with EGDT. And what they actually meant was, final print is with EGDT alone. So we have to, EGDT is not bad, it's good, but we have to understand that it's good only in resuscitation phase, only in first 24 hours. We can be liberal with fluids only if we have capacity enough to later manage and not just manage, later manage to pick up early signs that when it is enough. So that's the point here. So moving on, we try to find an answer to the first question, when to start fluid therapy. Easy, resuscitation phase, we are not holding back anyways. So at the very initiation of this phase, answering the question is very easy. It will significantly improve cardiac output in almost all the patients who present in shock. See, my focus here is mainly on critically ill patients. So my talk is, you can assume it to be, we are talking about unstable patients right now who we deal with in emergency department and maybe in early phase of ICU admission. So after the first boluses of fluid, when we have given a certain amount of volumes, which is a golden figure yet to be discovered by mankind, what will that be, ml per kg dose? I think we'll never be able to find out or conclude on one, but we have to consider, we have to understand that fluids can improve cardiac responsiveness or preload responsiveness up to an extent. And identifying that point, when have we reached that point in Starling curve that we can now hold on fluids, is the key in clinical situations. And you have to assess it not on daily basis. I would stress, we were taught back 20 years like daily assess karo fluid balance. No, it's a dynamic process. I already mentioned, maybe every 4 hours, every 3 hours, you have to assess. With every change in urinary output, you have to assess whether I have already done enough for the patient. Because this is one situation, doing too good will be harmful. So we need to know when do we need to stop. So this is a classical, and you must have all gone through or read in books. This is nothing new. ROSE is what I already mentioned: resuscitation, optimization, stabilization, and finally evacuation. These are the 4 phases of fluid therapy we should be considering. How much to give, when to give, why to give, when to stop, why to stop. 5 questions we need to answer every day on our clinical rounds, and maybe morning and evening, every day. So what's the harm? What are we trying to do basically with this all resuscitation? We're trying to prevent organ damage so that the mortality decreases. All our scoring systems, SOFA scoring, Apache scoring, what do they count? How many organs are damaged? And let's predict the outcome. So what are we trying to do with the fluids here is preventing organ damage by maintaining organ perfusion. And how can we maintain that? We can maintain that with an adequate resuscitation, and then with the proper optimization and stabilization. Because organ injury, most of the times, if you see the point in first graph, It's in first 24 hours. It's a hit one. Most of the organ damage will happen with inadequate resuscitation on day one, though it will manifest on day 2 or day 3. To label it as AKI, it might, delay might be 48 hours, because by definition, we won't label it AKI until creatinine has doubled. It won't double in hours. It will not. It's going to double. It's going to take its own sweet time. But by the time we are already late, we have already reached our optimization or stabilization phase, and it's too late by then. So it has to be decided right there and then. And finally, even with the evacuation or after the evacuation phase, we can have hit 4, but that is related to I'll come to that later. It's JIPS related. Dr. Supradeep already mentioned in case 8. So I'll also be taking it slow in next slides. Next, please. So phase by phase, what are we going to do? These are some things which we need to follow, or if we can remember these few points in every phase of fluid management, we can do much good to our patients. So resuscitation phase starts within minutes of receiving a patient, can be for few hours till we have achieved stabilization. Usual mode of injury here is inflammatory. May it be traumatic, may it be septic, because it is causing metabolic disturbances or cytokine storms or high interval, whatever you say. There are a lot of theories about it, but basically it's a stage where we have patient who is unstable with some underlying inflammatory response. Trigger can be any. What's our goal? Early goal-directed therapy, no doubt about it. We go with it. We want to resuscitate this patient. We want the patient to survive and be stabilized within few hours so that we can actually work upon him. All your antibiotics, other strategies have no role, I tell you, till you have stabilized the patient. Of course, early antibiotics, early source control, as Sir said. But if it's a pneumonia, obviously you can't, take the lung off, but you have to stabilize the patient here. So our therapy is early administration, and we target for a positive fluid balance in first few hours. And what is the main risk? Usually still it is insufficient resuscitation, because somehow we have that 500 ml saline de do, chalo bolus 1 liter de do, fir maintenance laga dena. Have we actually assessed how much the patient may be requiring? Like I said, every patient is going to be different. With the peritonitis and third spacing, you really cannot know how much fluid you actually need until and unless you are documenting preload responsiveness from very beginning, starting very early in emergency department, and then only this can guide you probably ke kab mujhe slow down hona hai. Next, please. So in optimization phase, it might again last for hours to 1 day. Once we have given initial resuscitation fluids, we still continue to manage the shock. We might introduce vasopressors here when we have, finished with whatever volumes we have thought for resuscitation are given, and when we have deemed that it is necessary for the patient. And when does that happen? When there is no preload responsiveness. Easiest clinical way is if you're giving fluids and blood pressure is not improving, review it. Just don't keep giving it. It's the time to probably introduce your vasopressors and other supports, or maybe use some colloids such as albumin if there are no specific contraindications to such colloids. I am not in favor of synthetic colloids, of course, but fluid boluses here have to be guided by responsiveness. If we develop this into our practice in first 24 hours, maybe not for first 1 or 2 hours when we are actually resuscitating, but after that phase, do not get carried away by early goal directed therapy. ने बोला है कि fluid दे सकते हो, कोई बात नहीं, पहले 24 घंटे जितना भी दो, नहीं, ऐसा नहीं करेंगे. We will, after initial boluses, assess responsiveness. Response मिल रहा है, जरूर देंगे. We will not hesitate to increase our volumes, but volumes have to be assessed. How much, maybe on an hourly basis in first 24 hours, because main risk again this is the phase where both the risks come. In resuscitation phase, risk was only one, insufficient resuscitation. But in this phase, this is a phase which will decide whether we are resuscitating insufficiently or whether we are pushing the patient into a fluid overload situation. So you have to be very careful, especially in 6 to 24 hours of your patient. And there's a, I tell you, classical thing. Resuscitation phase usually emergency department mein khatam ho jata hai. ICU mein aake, it is in optimization, stabilization phase, and that is what is expected of us in critical care. That's where our skills should lie. Keep assessing on an hourly basis. Just don't follow anything blindly. Next. I think एक miss हुआ बीच में. Yeah. So हम पहले ही आगे थे. Yeah. So in stabilization phase, again, like in optimization phase, the risks are same, but chances of going into fluid overload side here are more. So here, what we follow, what should our goal be? It should be late conservative fluid management, right? So we now start getting conservative. Maybe on day 2, we just keep reassessing, and we only provide for normal maintenance and replacement therapy. And if patient is still unstable, this is the right phase to re-evaluate. Are there any secondary causes of instability in this particular patient? So that's how we should go about it. And finally, it's evacuation phase. I must confess sorry first, because the goal here is early. No, it's late educate goal-directed fluid management. And what do we mean by late? Usually what happens in evacuation phases when we start, our goal here is, we start de-resuscitation, we start holding on fluids, and sometimes we end up holding more, being more aggressive, especially in patient on dialysis, because we at times have only one opportunity of SLED every 48 hours. So we usually get aggressive, 2 liter ultrafiltrate kar do. That's aggressive. That may be aggressive de-resuscitation for some of the patients. So we, it still requires goal-directed fluid management, but on a conservative side. Now here we cannot be free. We'll have to keep our hands tight here, and we should try to achieve negative fluid balance, provided our patient is not in shock because of any reason, because excessive fluid removal may again cause hypoperfusion and secondary shock at this stage. Next, please. So that's about phases, how and what volumes. It's all about volumes till now. So about drug, much has already been discussed. By drug, what I mean here is a kind of fluid what we are using. What fluid should be there, for how long to use, how much to use. We'll be taking a quick review on that as final words. Next, please. So we should be equally careful while prescribing fluids as while prescribing blood products. They do equal harm. They're not as safe as we consider, because nowadays our focus is on preventing fluid accumulation. And so we should be considering all the factors of drug prescribing here also. So talking about normal cell line, it's not so normal. If we compare to plasma, it's already been discussed by Dr. Supradeep, so I'll be rushing through these slides now. Since strong ion difference in normal cell line is much less, so it has a basic tendency to be an acidotic fluid. So we do not consider it so normal nowadays, and focus is shifting towards balanced salt solutions, and we consider it's all about how much we can give. Again, I tell you, there is no hard and fast rule, but if we only need it for maintenance, our kidneys, with a normal functioning kidney, saline is good enough. But for large volumes, salines may not be so normal, or maybe even abnormal to use. So supraphysiological chloride levels, as Sir has already mentioned how they are harmful. They are, they result in narrow strong ion difference and reduce positive net strong ion charge, which can immediately with an immediate and compensatory response of hydrogen ion generation, because chloride needs some partner, right? So H plus is the partner it has in our internal milieu. So that's going to be generated, and this is going to be a acidotic milieu. But of course, normal kidney, always remember, kidneys are functioning normally. There is no harm with saline. But what happens in unstable patients is risk of AKI is so imminent that we want to be careful. We cannot predict which patient will go in AKI. So it's better to be on the safer side. If you have to err on the safer side, that's how balanced salt solutions get an edge, because we cannot predict in first 24 hours about organ perfusion and damage, which is going to only manifest in next 48 to 72 hours. So hyperchloremic metabolic acidosis with large volumes of saline does remain a concern, and to negate that, we have to consider how does it work, because it's basically a tubuloglomerular feedback system, which initially increases GFR, but then with increasing high chloride content with large volumes, it can increase the concentrations, and then macula densa senses and releases local mediators, and ultimately there is vasoconstriction of afferent arterioles, and GFR tends to decrease finally, and that's how it is somehow related to progression, or at least some contribution to acute kidney injury patient in unstable patients. So metabolic acidosis and hyperchloremia, they definitely go hand in hand with large volumes. They cause renal vasoconstriction and fall in GFR, as I already mentioned. They also have effects on other organs. Brother, you have to concentrate on me. Like GI side effects are also there. It does decrease visceral blood flow, the same vasoconstriction mechanism. It can cause disturbances in bowel motility. It can further cause cardiovascular side, where high sodium loads are not good for heart. We all know that. We have been taught that from MBBS days, second year onwards, maybe first year in physiology itself. We were taught sodium is not good. No, chloride also is not good. It always goes together, right? So we have side effects, other metabolic side effects like outflux of potassium secondary to metabolic acidosis. It causes. It's not directly linked. Saline does not directly causes hyperkalemia, but yes, indirectly by increasing the acidotic content of by decreasing the pH of blood to some extent, it can cause hyperkalemia. So why do we need balanced salt solutions? Because as I mentioned at the start of my talk, electrolytes are equally important. So solutions with physiological electrolyte pattern which matches plasma are best when especially large volume resuscitations are required. So a solution which achieves a physiological acid-base balance, or with bicarb, or with metabolizable anions like acetate, lactate, malate, and citrate, all are beneficial. There are more balanced salt solutions, we all know. Yeah, these are the common ones in use. Sterofundin, plasmalite, cabilite, ringers. You have already probably discussed this. The edge lies, of course, with the plasmalite and cabilite, because they maintain the closest osmolality to plasma, and their strong ion difference is also very close to plasma. Whereas ringers, though good enough, if you have limitations, but still it's holding the times and can be used fairly enough. If we talk about ringers, it has its own set of complications. Okay, what's here in these slides is about strong ion difference, which is less with plasma, and it's slightly hypotonic in nature, so may not be suitable for resuscitations, especially in neurotrauma with the traumatic brain injury. It is to some extent hypoosmolar, and some free water may be accumulated. And it also has disadvantages whenever liver dysfunction is predominant. Sir has already dealt with that, so I'll be taking you quickly through it. We'll just, because this has already been discussed, I'm not going into depths of it. So One concern with lactate here may be with the diabetic patients who receive large volumes, they may develop delayed hyperglycemia after 24 to 48 hours when all this excess lactate is being converted to glucose with the gluconeogenesis process. So overall, contraindications to lactate ringers are generally uncommon and they're fairly mild, probably not suitable for neurotrauma and traumatic brain injury, but otherwise it's a good solution which can be used in the absence of balanced salt solutions. If there is some crunch, you cannot use it. So same thing again, what we are trying to achieve is lesser electrolyte disturbances with larger volumes. That's the whole crux of matter. Whatever we have to give, it should not cause any disturbances in fluid and electrolytes balance. So incidence of hyperkalemia with the use of balanced salt solutions in perioperative period, especially with the patients who have renal disturbances, it was evaluated and it was found that it causes even lesser hyperkalemia compared to other solutions. Now, coming on to some trials which concluded, I'll be quickly rushing through with the just conclusions. And SMART trial was one important trial which was published in 2018. Large number of patients, almost 16,000 patients were studied, which received 50-50 almost balanced salt solutions and normal saline. And what they wanted to assess was there any major kidney related event in first 30 days and any composite of death from any cause. So almost similar results, slightly lesser, but not significant. So we cannot conclude here whether saline causes more kidney injury than balanced salt solutions. But of course, all these studies have to be, relooked maybe because stability of patients is what matters whenever organ perfusion is at stake. So similarly, yes, chloride levels were definitely more with normal saline. More than 110 was reported in 35% compared to 25, almost 25% with balanced salt solutions. So yes, this was a significant complication, and bicarb levels were better maintained with balanced salt solutions when large volumes were used for resuscitation. So the use of balanced crystalloids for intravenous fluid administration resulted in lower rate of composite outcome of death from any cause, less need of new renal replacement therapy than with the use of saline, probably attributed to lower chloride levels which were maintained. So when we look at use of balanced salt solutions in critically ill patients, this study was published in Annals of Pharmacotherapy in 2020. And what they assessed was association between crystalloid fluid given to the patients and outcomes clearly. Studied 30,950 patients, which is a huge number. And outcome only in the terms of mortality was seen. Next. And renal replacement therapy, they observed that new acute kidney injury occurred less frequently than with the use of saline, and it was better with the balanced crystalloids. So conclusion, lower hospital mortality compared with saline in critically ill adult patients, but not specifically those with sepsis. So balanced crystalloids should be provided preferentially to saline in most critically ill adult patients, especially those who requires resuscitation. Even in diabetic ketoacidosis, the case discussion has already been done. We can, with fair confidence, use despite electrolyte abnormalities, because ultimately what are we trying to do in DK? Establish a normal metabolic status. And that can only be done with a fluid which is closest to plasma. We cannot do it with something which is not even closer to plasma. So it definitely, and even in studies, it was proven that time to insulin stoppage, discontinuation, and to decay resolution was shorter enough with balanced salt solutions. So when in another study, which is again a recent one, just last year in 2021, published in JAMA, and they tried to study the effect of intravenous fluids with the balanced solution and with saline on mortality in critically ill patients, and primary outcome was 90-day survival. This study could not establish superiority of any, but they concluded use of balanced solution compared with saline did not significantly reduce 90-day mortality. But findings and the findings do not support the use of this solution. Next. But there was a post hoc analysis to this, which was published in 2022 March, this year itself, that there is a high probability that balanced salt solution used in ICU reduces 90-day mortality in patients that exclusively received balanced fluids before enrollment. What were they trying to stress upon was, as I already mentioned, most of our resuscitation phases dealt within emergency department. And study was done in the critical care units where already resuscitation phase was over. So to move on, then again, similar post hoc analysis was already, there was a published data, and in CEST, it was published with that relative impact on sepsis outcomes of fluid composition during early resuscitation in emergency department versus after ICU admission. And then they compared 30-day mortality. And then they concluded that among patients with sepsis, the effect of balanced crystalloid versus saline on mortality was greater among patients for whom fluid choice was controlled, starting in emergency department itself. So that's where larger volumes are given. It's game of volumes. Basically, whenever we need to give more volumes, we need to consider the profile of electrolytes and pH of what we are prescribing. So that's the whole thing. So definitely there are a lot of advantages of balanced salt solutions. And regarding, we have already discussed the drug. Regarding duration, timing of fluid therapy is more important than volume. So we know the concept of golden hour. I'm not going into detail when to start. We have to start as early as possible. We've gone through the phases. We know the how much to give, what are our goals in different phases. But it has been shown that treating critically ill patients who required fluid resuscitation aggressively and early, they have better outcomes than those patients whose fluid resuscitation was delayed. Finally, the same slide as Sir has mentioned, this is something which is coming in focus from last couple of years. We should not overdo things. We need to learn when to stop. Probably first 24 hours, if we divide them further, first 6 hours, we can probably not hold on, but just after 6 hours, 7 hours, or as early as patient has hemodynamically been stabilized, we should start considering that we are not pushing the patient into this situation. So to conclude, crystalloids are the choice of fluids. Timing and appropriate volumes in each phase is key to success. There are definite advantages to balanced salt solutions, including survival and including lower incidence of renal replacement therapies, and de-escalation, finally, as we stressed upon in this whole symposia, as and when stability is achieved, should be considered. Thank you very much. I conclude here. I think we'll be open for any queries and questions. Sir. Everybody's over.
So, and the only fluid I can offer you here is super water. I think there are no questions left, or
If there are any. Ma'am, I really don't think we can do that. It's about stability. If we are entering a fluid overload state, Maybe, but what was the logic behind that? I need to understand. Why did they introduce this concept?
Maintenance fluid. And after that, and patient becomes oliguric, 0.3 ml per kg body weight. And suddenly he is rushed on some more fluid. Now, one of the reason why these patients are oliguric is postoperative state is a stimulant for releasing antidiuretic hormone. So there is a physiological relay, pain, many drugs, postoperative stress itself can increase the ADH relay. So you can have a urine output less. But we cannot have a blanket statement that 0.3 ml per kg body weight allow kar do. A patient is, so you have to see the perfusion marker. So the thing is we have to see the, so the more important thing is to see the perfusion marker. And perfusion, see the capillary refill time. This is the most important perfusion marker we often forget. Capillary refill time, whether the patient is, it's not urine output alone. If the patient is hypoperfused and having decreased urine output and patient is fluid responsive, possibly, then you should give fluid. But if the patient is not hypoperfused, just having urine output of 0.3 ml per kg body weight for maybe 2 hours, 3 hours, 5 hours, then there is no point giving fluid at all. So that's maybe the concept. Otherwise, but we cannot have a blanket statement that sub mein
That's
0.3
where
ml
actually,
chal jayega. No.
No.
So it is postoperative.
It's-
Postoperative,
Well,
but not in all postoperative patients. Somebody is hypoperfused and you are not giving fluid, that's probably not acceptable.
Ma'am, probably point here is at what phase of resuscitation you are. We all know if patient will be fluid overloaded, there will be gut edema. Your anastomosis is not going to hold. And if there is a peritonitis again, because of leakage of anastomosis, anyway, it will not work. So that's where the concept probably we also do accept, or we take help of nephrologist to de-resuscitate if we have to give fluids on other side. No, it's basically, again, if you go by the basic principles, you have to decide which phase of resuscitation you are in. If your patient is already overloaded and you do not want to increase on your maintenance fluids, there is a secondary reperfusion injury also because of edema, because of something we did not discuss in here is GIPS, which is global increased permeability syndrome. The patient on third day is entering into that phase where we have given enough fluid and now it is causing, now there is a stage of increased permeability because of maybe inflammation, which can be a post-surgical stress or which can be a primary focus of because of infection. We hold on to fluids at times despite the fact that urine output is decreased. We do take those decisions, but yes, it's in a scenario where you are sure that you have already filled up your patient enough.
I think we can discuss further in the dinner time.
Let me congratulate. It's a beautiful deliberation. Me as a Dr. Pradyum Sharma, most of the time we have been discussing is diabetics and hypertension, so many talks. But this is a basic crux in the management of a patient. Still we have been, because of most of the books and the literature, they say 0.9% normal saline, generally it's been discussed. And today probably I'm the first to come across BSS. So I don't understand what do you mean by BSS, because Harrison, all the carries meaning is the 0.9% saline, number one. Number two, in many of the hypertensive patients who come to you with a hypovolemia, and once you infuse, they just land up in the hypertensive episode, number one. Number two, post-operative, they retain a higher
I didn't get
level.
the second question. You said hypertensive patient?
In our practice time, many patients who come with the dehydrated patients primarily because of low intake or primarily because of gastroenteritis,
Hypotensive patient.
hypertensive patients landing into you with a hypovolemia because of primarily.
Okay.
So our generally approaches, we go with a 0.45 saline. So not to make it as more sodium retention, and even post-operative, when they have a normal tense, they don't require much of fluid, but we try to put it as a 0.45 saline. So what do you take on this?
So first, regarding the first question, the balanced fluid solution. Balanced fluid solutions are, the term is coined to see the solutions which has got a electrolyte composition closer to the plasma. But we do not have acetate in the blood, very minuscule content, or lactate content is less than 1 millimole per liter. So it's not exactly the plasma, but it is closer to the plasma. But 0.9% saline has got only sodium and chloride, and they are in a supraphysiological volume, like quantity. So this is the first question. Regarding the second question, sir, we need to understand this term dehydration and the term hypovolemia are used interchangeably, probably not in the right manner. The term hypovolemia means patient who has got intravascular fluid depletion, intravascular volume depletion. Term dehydration is when you have total body fluid depletion, all three compartments: intracellular, intravascular, and the interstitial fluid. So this is, so if there is a hypovolemia, intravascular volume depletion, then we have to give a fluid which remains in the intravascular compartment for a longer period of time. For example, we have quoted a patient who has got a hypertensive or diabetic or whatever. But if this patient is now hypovolemic, intravascular volume is depleted, then we have to give a fluid which remains in the blood for a longer time. And that's an isotonic fluid. So 0.45% saline or half DNS or 1/4 NS, none of them has got any role in. Here we have to give either a saline or a ringal lactate or KB light or pyrofundine, something like that. Or maybe specific circumstances we can give colloids. But this is for hypovolemia. But once the hypovolemia is corrected, patient is well perfused, capillary refill time is good, blood pressure may or may not be good, patient mentation is good, passing some urine. In that case, to correct the further volume in the intracellular compartment and in the interstitial compartment, you may give 0.545% saline, but not initially.
No, it's a part because the first.
And
given
regarding
hours-
this, there's an excessively exaggerated statement that that hypertension will produce the saline for this will produce this. We need to see the context. In the right context, we need to give this. Yes, if you keep on giving saline, that will produce sodium overload.
That's the way my questions. Thank you.
Thank you, sir.
Thank you, Dr. Supradeep. I think we'll just have we'll finish this off with a memento presentation. So I request Dr. Shabbar, who's here, to please come here. And I would like to congratulate him because he's just been awarded the Pride of Rajasthan, Dr. Shabbar. So Dr. Supradeep. So first, you all will give him. And now he'll give it to Dr. Supradeep. Request Dr. Rajneesh to please come and give it to Dr. Achint. A big thank you to Fresenius for making this possible. So I request Mr. Mohit and Yusuf, please.
Yes. So I would like to congratulate Dr. Pankaj Anand for such a great event, I must say, and such a nice initiative as ACE. And today, actually, we were very much benefited by all the three lectures. Like Dr. Anand started from the roles of these fluids in various neuro trauma patients, TBI patients, which was followed by an amazing lecture, which was quite interactive as well as informative, particularly the case-based scenarios that we had from Dr. Ghosh. And actually, he touched upon almost each and every part of selecting a fluid for different situation, how all the available fluids would be of some importance in all of this. And of course, Dr. Narang, in spite of these adversity, he actually managed to come by road from Chandigarh. So that was amazing of you, Dr. Narang. So we again thank you. And which was again after 8 to 9 hours of road travel, he delivered such a great lecture. So again, thank you. So overall, this was an amazing, informative and educational initiative and event. So from my company's perspective also, we would like to engage in many more such future events. And we thank ACE team and all the dignitaries as well as the esteemed speaker for being with us. And thank you everyone, and enjoy the dinner now. Thank you.